Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home-related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is Sepsis in Long-Term Care Case Scenarios. This is part 2 of a 2-part series. Last week's webinar was an overview of sepsis in long-term care. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, you can submit them to us using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week, we will not be having webinars since Quality Insights will be closed for the Juneteenth holiday, but we will return Wednesday, June 26th at 2 p.m. Our planned topic that week is sepsis prevention for dialysis in the nursing home setting. And now I'd like to introduce our guest today, Carolyn Pandolfo. Carolyn is a travel infection preventionist for the Pennsylvania Project Firstline team at the Pennsylvania Department of Health. She is a registered nurse by trade with backgrounds in public health education, wellness coaching, behavioral health, and project management. Located in Pittsburgh, Carolyn is currently pursuing her Master of Public Health degree online from Boston University. Carolyn, welcome and thank you for joining us today.
Great, thank you so much for having me. All right, can everybody see the title slide of the presentation?
Yep, it looks good.
All right, excellent. So if it's okay with you, I guess we'll go ahead and start. All right. Well, hello, everybody, and welcome to Sepsis in the Long-Term Care Setting. This is part 2 of the 2-part series that Kathy mentioned. So again, my name's Carolyn Pandolfo. I use she, her pronouns, and I'm an infection preventionist, proudly representing PA Project Firstline with the Department of Health. And I'm going to be your presenter today for part 2 in partnership with Quality Insights. So our commitment at PA Project Firstline is to provide you with valuable insights and knowledge that will empower you to enhance infection prevention and control practices within your unique long-term care setting. So in this session, we're going to be focusing on expanding what was touched upon in part 1. So talking about, of course, ways to address and prevent sepsis and trying to go over case scenarios that might be specific to what you would see in long-term care. So we really hope that you find this webinar informative and valuable for enhancing your facility's infection prevention and control practices. So that said, thank you for joining us, and we'll go ahead and get started. So we are going to cover very much the same objectives that we covered in last week's part 1 session, but to kind of recap those, we are aiming to identify at least 3 signs and symptoms of sepsis in long-term care residents. We want to describe 3 or more interventions for sepsis surveillance and treatment, demonstrate understanding of at least 4 best practices for early detection and prevention of sepsis, and then finally, apply 3 or more sepsis prevention and control strategies to your unique long-term care environment. So what do I mean when I say unique long-term care environment? So let's talk a little bit about that. Last week, Emily would have covered with you all kind of what the different long-term care environments look like. So everything from skilled nursing to intermediate care to group homes to personal care, assisted living, and really everything in between. So to expand upon what Emily spoke about last week, we're going to talk a little bit more about sepsis and then dive into some of those case scenarios. So when we have a resident who maybe returns to us after surviving sepsis, we really want to know a little bit about what that survivor experience really is going to look like. So we're going to shift gears into sepsis survival and recovery. So last week, Emily would have spoken about PSS or post-sepsis syndrome, but there are other long-term effects that can result from sepsis. So something we want to note here is that more than half of older adult sepsis survivors endure worsened physical and cognitive functioning, and that could be with or without having PSS. So older adult sepsis survivors could also face 1 to 2 new limitations on activities of daily living following hospitalization. So that's something significant that we want to note. But speaking of hospitalization, we want to take a look at readmissions. So more than 40% of older adult sepsis survivors are readmitted to the hospital within 3 months, and up to 2/3 of hospital readmissions following sepsis are related to infection. So last week, we would have covered how those repeated infections are very common for sepsis survivors, and it could really lead to those hospital readmissions, especially in such a short time frame. And then finally, there is caregiver impact, which we want to note. So these are the folks who regularly care for our residents, whether they're family members or members of your healthcare team. Really, anybody caring for that resident with critical illness could be at higher risk for poorer mental health outcomes and things of that nature. So that said, surviving sepsis really doesn't just impact the resident, it could impact those closest to them. So something else to note about sepsis is the cost. So when we talk about the cost, there are two perspectives that we want to consider, and those are the human cost and the economic cost. So when we think about the human cost of sepsis, there are 11 million lives lost each year around the world due to sepsis, with 350,000 of those deaths occurring right here in the United States. So approximately 1% of survivors will face at least one surgical amputation due to sepsis. And we talked a little bit about those last week, how that decreased perfusion could really lead to that rapid tissue death. And that's what could result in those amputations. So with that in mind, about 1% of those survivors could have at least one or more surgical amputations. And unfortunately, sepsis survivors also bear the burden of a decreased life expectancy overall. And then, of course, there's the economic cost to consider. So sepsis is the leading cost of hospitalization right now in the United States. And acute sepsis hospitalization and skilled nursing care in general can cost up to $62 billion annually. So it is a very high economic cost as well. So hospital readmission at 30 days following sepsis could cost about $16,852 per patient. So that's significant. So these costs really represent some of the impacts that we don't always think about right away when it comes to sepsis, but they are important to remember, so we want to highlight those. So it's also important that we take a moment and talk about sepsis and health equity, because there are some notable health disparities related to sepsis, one of which includes race and ethnicity that I want to talk about. So incidence and mortality rates of sepsis are higher, unfortunately, for non-white individuals, and those non-white individuals often face significantly longer wait times and lower priority status in the emergency department. So I want to take a second and unpack that because, as Emily would have spoken about last week, sepsis is a very rapidly progressing response to an infection. So the longer an individual waits for treatment of sepsis, the less likely they are to survive it. So if a person's experiencing a significantly longer wait time and lower priority status at the hospital, that could have extremely adverse consequences and an increased likelihood of death for that patient. So it's a very harsh reality to process when it comes to racial and ethnic health disparities. So we want to be mindful of that for our residents. There are also some socioeconomic disparities worth noting. So for example, adults with reduced levels of education and financial resources are more likely to die from sepsis. And then finally, there are awareness and language proficiency disparities. So sepsis patients with limited English proficiency, or LEP, face an 80% higher mortality risk. And there are many reasons for this. So this is why it's extremely important to have the resources necessary, both in the long-term care setting and at the hospital, to communicate effectively with those who have LEP. So knowing what's wrong with our resident or our patient and knowing how we can help them is going to not only expedite their care, but really increase their chances of survival, which of course is what we always want. So we also just want to highlight some aspects of sepsis that are specific to long-term care populations, the first of which of course is age. So at least 70% of adult patients with sepsis are age 60 or older. Of course, not all long-term care residents are age 60 or older, right? So we have younger residents that come across and come through long-term care for all types of reasons. But very commonly, we do see residents that are in that age category of 60 and up. So the fact that 70% of adult patients with sepsis are in that age category is significant for long-term care. We also want to emphasize risk. So nursing home residents specifically are 6 times more likely to pursue emergency care for sepsis than non-nursing home residing adults. When it comes to aftercare, adult sepsis patients are 3 times more likely to be discharged to long-term care. So we may admit and readmit a high number of sepsis survivors to our facilities. And then finally, there's disability. So older adult sepsis survivors tend to endure more long-term disabilities than other adult survivors. So as a healthcare workforce, we really need to recognize what it means to be a sepsis survivor and work together to meet the needs of those survivors in our unique long-term care settings. So shifting gears now, we want to break down some of the common challenges that long-term care settings face in general and how that impacts infection prevention and control efforts. So one is communication and collaboration. So things like delayed recognition or reporting of infection could lead to worsened outcomes and could be a huge barrier for addressing sepsis. So ineffective interpersonal or interdisciplinary communication could also lead to breakdowns in this process. We also have challenges related to knowledge and resources, right? So issues like staffing shortages or workforce burnout could really lead to and contribute to challenges related to addressing sepsis, as well as reduced laboratory and clinical capacity. So for example, last week, Emily would have spoken about the ability to conduct POC testing, as well as testing through a laboratory. So if there's reduced capacity at the lab or fewer members of our healthcare team on site to actually assess residents and conduct POC testing, that could potentially be a barrier. And then finally, there's antimicrobial stewardship. So limited awareness of that antimicrobial resistance, or AMR, that Emily spoke about last week, and the interventions needed to address it could really be a challenge in long-term care settings. So this could potentially increase the risk for development and spread of those multi-drug resistant organisms, or MDROs, that Emily spoke about last time. And there's a link here on this slide to some really important interventions from the CDC on the core elements of antibiotic stewardship for nursing homes. So we really recommend accessing that link at a later time and review those core elements, because those are specific to long-term care. So they're very, very helpful. The good news is, though, that with challenges come solutions, and that's why we're here talking about this today. So we want to call your attention to the 2023 Hospital Sepsis Program core elements, and those were released, of course, in 2023 by the CDC. So similar to the core elements of antibiotic stewardship for nursing homes that we just mentioned, the core elements are tailored more for the hospital setting. However, they absolutely apply to long-term care, so don't feel like this only applies to hospitals. So what are the 2023 Hospital Sepsis Program core elements? Well, they are a framework intended to monitor and optimize hospital management and outcomes of sepsis. So again, this absolutely applies to long-term care. They really complement the existing CDC sepsis guidelines, which include hospital leadership commitment, accountability, multi-professional experience or expertise, action, tracking, reporting, and education. So we're going to look at each of those things in greater detail and talk about how to apply them to our own unique long-term care settings. So again, we strongly encourage accessing the link on this slide and reviewing the 2023 Hospital Sepsis Program Core Elements Guide in its entirety. We're going to kind of look at it in a more abbreviated way today for the sake of time, but when you have a chance, definitely click that link and read them in detail. So breaking down hospital leadership commitment. So what does that look like? So the CDC defines this as dedicating the necessary human, financial, and information technology resources to the facility. Again, this can absolutely be done in long-term care, and to help address the challenges that we've discussed, this could be a really great way to enhance interdisciplinary communication and even bolster facility capability. So accountability. So this refers to appointing a leader or co-leaders responsible for program goals and outcomes. So when it comes to sepsis or to IPC in general, this could really help promote trust and even alleviate the challenges that the frontline team may face. And then there's multi-professional expertise. So this involves engaging key partners throughout the hospital and healthcare system, which of course applies in long-term care organizations as well. And leveraging multi-professional expertise could be a really great way to increase knowledge, foster a sense of support, and build clinical capacity. So another core element is action, and that's defined by the CDC as implementing structures and processes to improve the identification of, management of, and recovery from sepsis. So this could be a really great way to reinforce awareness of AMR and antimicrobial stewardship efforts. Next, we have tracking and reporting, which really go hand in hand. So tracking refers to measuring sepsis epidemiology, management, and outcomes to assess the impact of sepsis initiatives and progress through program goals. And reporting is providing information on sepsis management and outcomes to relevant partners. So these are truly effective ways to strengthen surveillance and promote quality improvement initiatives within the long-term care setting. And then finally, we have education. So this entails providing sepsis education to healthcare professionals, patients, and families and caregivers. It's always so important to remind ourselves that our residents' families and loved ones are part of the care team. So anything that we can do to provide not only ourselves and our residents with knowledge and information, but for our residents' connections as well, is going to be a great way to empower the community as a whole, because knowledge really is power. All right, so we want to pause and move away from all of the talking and really see what we've learned so far. So as indicated in the title of this webinar, we're going to review, answer, and discuss 4 case scenarios to check your knowledge from part 1 and from a little bit of what we covered today in part 2. So bonus points if you pick up on what these 4 scenarios have in common. I'm just going to say that right off the bat. But let's dig into the first one. So Mrs. Petrillo is a resident in a small personal care home. She's an 80-year-old sepsis survivor with a history of diabetes mellitus. A certified nursing assistant, or CNA, alerts the director of nursing, or the DON, that Mrs. Petrillo's resting heart rate is 120 beats per minute, her blood pressure is 90/60 millimeters of mercury, and her oxygen saturation is below baseline. She's febrile, disoriented, and clammy to the touch. So suspecting sepsis, the DON assesses Mrs. Petrillo. Affirming his suspicions, what is the most appropriate next step for this resident? A, start an intravenous or IV catheter to increase fluid intake. B, activate EMS immediately by calling 911. C, begin cardiopulmonary resuscitation or CPR. Or D, provide oral fluids and reassess in 15 minutes. So we'll give folks a second to think about these answers and maybe respond in the chat with what you think the correct answer is. Okay, do we have any responses coming through?
One person replied in the Q&A that they thought it was A.
A,
A couple
okay.
people in the chat are saying B.
B, okay. All right, great. So if you said B, you would be correct. So we would absolutely want to activate EMS immediately by calling 911. And the reason for that is, although starting an IV is a correct intervention, that's something that's going to be done in the ambulance or at the acute care hospital. So that's not something that we want to attempt to do while they're still in the long-term care setting. That's something that EMS will take over or that will be initiated at the hospital. So CPR would also not be a valid intervention just based on Mrs. Petrillo's present condition in this scenario. Also, providing oral fluids may or may not be okay depending on the situation, but we would never want to leave a resident for 15 minutes to be reassessed when we suspect sepsis. So very good job. All right, so we're going to move on to our second case scenario. So we have Mrs. Nyland, who is a 68-year-old resident of an independent living community, and she was recently hospitalized for a heart attack. She survived sepsis while inpatient and was later discharged to a subacute care facility for rehabilitation. While weaning off a ventilator, Mrs. Nyland's registered respiratory therapist, or RRT, notices a clump of hair on her bed and rashes on her upper extremities. After providing respiratory care, the therapist shares their observations with nursing staff. Mrs. Nyland is assessed by a registered nurse, or RN, who reports her findings to the physician. To what may the physician attribute the cause of these symptoms? A, ventilator-associated pneumonia, or VAP. B, septic shock. C, allergic reaction. Or D, PSS.
We have one vote for D.
Okay, someone's saying D. All right, any other responses?
Got a vote for C.
A C, okay.
Another vote for D.
All right, very good. So I see folks are putting responses in. So if you said D, you would be correct in this scenario. So recalling what Emily spoke about last week regarding PSS, or that post-sepsis syndrome, skin rashes and hair loss are common symptoms that sepsis survivors may have. So in this scenario, Mrs. Nyland, she had the skin rashes and the hair loss, so this could very well be PSS. And although ventilator-associated pneumonia could be developed during ventilator care, Mrs. Nyland didn't exhibit the VAP symptoms that we would typically see, and her condition would likely be far worse if she was in the stage of septic shock. So I know somebody had said C for allergic reaction. So although rashes could indicate an allergic reaction, that's certainly not outside the realm of possibility. The hair loss and the recent sepsis survival would more likely point to potentially having PSS as a possible cause of her symptoms. So yeah, that's a tricky one. So nice job, everyone. All right, so we'll go through our third case scenario here. So we have Mrs. Spornak, who's visiting her 87-year-old father, Sal, in a skilled nursing facility. Sal has chronic obstructive pulmonary disease, or COPD, and currently receives 4 liters of oxygen via nasal cannula. A physician enters the room and shakes Sal's hand while introducing himself. During this interaction, Ms. Spornak notices that the physician did not perform hand hygiene upon entering the room. Concerned about Sal's ability to fight infections, what could Ms. Spornak do to help protect and advocate for her father? A, ask the physician to perform hand hygiene the next time he enters Sal's room. B, note the interaction to discuss later with the nursing home administrator, or NHA. C, politely remind the physician about hand hygiene and help Sal sanitize his hands before touching his face or surroundings. Or D, trust that the physician knows what he's doing and assume that he performed hand hygiene while out in the hallway.
Lots of C's coming in.
A lot of C's. Okay, very good. So if you said C, you would be correct. So we'd want to politely remind the physician about hand hygiene, and then we'd want to help Sal sanitize his hands before he touches his face or really anything else in his immediate surroundings. And it is always okay to remind any member of the healthcare team, regardless of their role, about hand hygiene, because it applies to everyone. So we want to empower family members and loved ones of our residents to remind the healthcare team to do that. A lot of times in our facilities, we see signs posted that say, intended for the patient or for the resident that say, remind your healthcare worker to clean their hands. And that's kind of what we're going for here. So we're calling back to that, making our intention prevention, right? To help clean hands stop the spread. So very good. All right, so we have our fourth and final case scenario. And when we're done, we can certainly go back and talk about any one of these, but for now, we'll dive into the fourth one. So Mrs. Devereaux calls the Intermediate Care Facility, or ICF, where her brother Tad lives. Tad has intellectual disabilities and often struggles to articulate how he feels. 3 days ago, Mrs. Devereaux noticed signs that Tad may have COVID-19 and reported this to a direct care worker. Today, she asks the house manager for an update on her brother's health status. Unaware that these concerns were reported, the house manager asks for more information. Tad is quickly assessed and tested for COVID-19. The house manager confirms that he is positive and initiates IPC protocol. So which factor may have delayed the identification of this infection? A, ineffective communication and documentation. B, interpersonal conflict. C, AMR, or antimicrobial resistance. Or D, staffing shortages and low morale.
Got a couple A's, another A.
Okay, very good. All right, so if you said A, you are correct. So it would be that ineffective communication and documentation. So had this miscommunication not happened, or had Mrs. Devereaux's concerns been acted upon or at least documented somewhere, then Tad could have been assessed sooner for COVID-19. So if he were to develop sepsis from this infection, that earlier identification and treatment for the virus could be critical to preventing sepsis. So this goes along with that core element of action that we talked about in those 2023 hospital core elements from the CDC. So although interpersonal conflict could arise from ineffective communication, that's certainly plausible, the situation itself really didn't arise from a dispute, and AMR was also not a factor in the situation and did not contribute to the delay of the identification. And of course, although staffing shortages and low morale could have contributed to the communication breakdown, those factors didn't directly delay the identification. So very good, very well done. All right, so we'll talk a little bit about some key takeaways from part 1 and part 2. So we want to just kind of summarize what we've learned so far. So we know that sepsis is a life-threatening response to an infection, and it progresses very quickly in stages. immediate recognition and treatment of sepsis is going to be absolutely critical for survival. So like we talked a little bit about that earlier with whether or not we want to call EMS. In long-term care, we don't want to attempt to treat. We always want to recognize it quickly and call for help. So IPC protocols in long-term care are essential for preventing sepsis from occurring. And then finally, long-term care settings are diverse and face unique challenges and solutions related to IPC and sepsis. All right, so we want to take a moment to thank you all for your time and attention, both from attending part 1 and today for part 2. So we really welcome any questions, comments, feedback, discussion points that you may have, and we can certainly talk about the case scenarios as well if anybody would like to review or re-review those. So feel free to take this opportunity to participate in open forum.
Thank you, Carolyn. As Carolyn said, if you have a question, please submit it using either the chat or the Q&A tool. You could also raise your hand if you'd like to ask your question out loud. While we're waiting, I would like to again invite everybody to our next webinar, which will be Wednesday, June 26th at 2 p.m. That webinar will be on sepsis prevention for dialysis in the nursing home setting. We invite everybody here to bring their questions and comments to our virtual live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics like quality improvement initiatives, infection control, or MDS coding. And you can find the links to our live chats and webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org and I will get you on that list. And I will put my email in the chat shortly. And I will also right now put the presentation slides from today in the chat for anybody who needs them to see those resources that Carolyn shared. And I don't see any questions so far. Carolyn, do you have anything you would like to add before we wrap up?
Yeah, just, in the spirit of preventing sepsis, just wanted to share some resources from PA Project Firstline. So you can absolutely visit our homepage, which has a ton of resources on it, and it's linked here on the slide that you see on your screen. And you can also contact us directly at ra-dhfirstline@pa.gov. So if you do have questions or thoughts or any feedback that you want to share with us, you are absolutely welcome to use that email address. And there's also a third link here on this slide where you can actually request free on-site IPC education from us, which is really exciting. So Emily would have mentioned last week that our team has 3 traveling infection preventionists, myself included, and we'll happily come to your facility and provide you and your team with any free infection prevention and control training, including this one. We can come in and talk about sepsis too. So you could also text JOIN to IPC4U to receive text updates from PA Project Firstline. We send them out every Friday, so that way you can kind of just get some quick IPC tips on the go, and they're really, really helpful. But other than that, I didn't have anything too much else to add other than some resources from the PA Department of Health, the PA Department of Health's Long-Term Care RISE program, and there are regional contacts listed here on your slide. And then also the PA Department of Human Services has some great resources on disability and aging. But that's it. Really appreciate everyone attending part 1 and part 2. PA Project Firstline sees you and recognizes and appreciates all the work that you do. So I just want to personally thank you all for everything that you do for our residents.
Thank you, Carolyn. And since it doesn't look like we have any questions for today, I will go ahead and wrap us up. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Carolyn, I'd like to thank you for joining us this week and for this presentation. And I'd like to thank everybody here for joining us. We hope to see you again soon.